Namaskar, everybody. This lesson, I'm going to talk about atypical Parkinsonian syndromes, a clinical approach. I'm Partha, a neurologist, National Professor in Neurology, and presently working for the National Health Service in England. This is me. I am a Kolkata medical graduate from 1990 batch. After completing my MD from India, I moved over to the UK to train in neurology and then to work for the National Health Service, treating patients and undertaking teaching commitments and training commitments and undertaking research as well. I'm a member of several Indian and international neurological and neurological affiliated organizations. I would like to start this lecture by offering my sincere respects to Professor Arun Majumdar, who passed away from the COVID illness early on in May this year. I have known him only virtually, and he is reputed to be an extremely good teacher, and I had a first-hand experience of him undertaking good teaching and good CAPE discussions on the API forums that the West Bengal branch undertakes. I salute to Professor Majumdar, and we're very sorry for his loss. I dedicate this talk also to the COVID warriors who laid down their lives in the line of duty, including the recent second wave, where a number of our COVID warriors have become martyrs, and also to the countless lives of patients that are being lost and damaged through COVID. With those somber thoughts, let's get along with my talk for today. I have no conflicts of interest or any financial disclosures to report to you. Parkinson's disease is going to increase in numbers in India as well as in the whole world in the coming decades. Neurodegenerative diseases increase as people live longer, and we are living longer in India. So we'll have a huge number of Parkinson's disease patients to look after, and we need adequately trained doctors to be able to diagnose and treat those conditions. Cerebrovascular disease causing Parkinsonian syndromes will also increase in number in the coming years, with hypertension and diabetes having reached epidemic proportions, and metabolic syndrome and obesity, both in children as well as in adults, reaching world epidemic proportions. Parkinson's disease still remains a clinical diagnosis. There are lots of mimics of Parkinsonian syndromes, like I outline here: multiple system atrophy, dementia with Lewy bodies, PSP, CBD, CBS, vascular Parkinsonism, drug-induced, other rare Parkinsonisms, and toxins causing Parkinsonism, to name the common ones that we will have to diagnose and treat accurately. I'll be showing a large number of videos in this presentation. There'll be a few guidelines and charts that I will quickly go through, because this video you can look at leisure after the talk as well. I would request you, out of respect for the patients who have given up their confidentiality and their privacy and expect us to protect their dignity, to not take any videos or photos of the patients, please. That's my earnest request. Right. So the topic of atypical Parkinsonism arises since a lot of patients look like Parkinson's disease. And I've given you a lecture on the last occasion of what Parkinson's disease classically looks like. But a number of other conditions which were in the previous slide look like Parkinson's, but turn out to be other conditions in the longer term. And postmortem is the definitive diagnosis, although imaging criteria are gradually evolving, but are yet not cast iron or definitive. So we have to rely on the clinical history, which is so very important, including in COVID times, where we are re-emphasizing the value of history and examination to give us the diagnosis rather than falling back on investigations which do not give us the answer accurately in all the time. So, to start off the red flags, what raises my inquisitiveness as to a particular patient not having Parkinson's disease? If the disease is progressing very rapidly, if there are early gait instability features or the patient is falling, if the tremor is not a profound manifestation, if there are other movements like tremors and myoclonus, and if there is any poor or absent response to levodopa, then we start to think of the atypical Parkinson's. There are other phenomena as well, like if the patient has abnormal eye movements. We have been taught from third year that these are possibly the PSP-like illnesses. If there is a lot of pyramidal tract signs or cerebellar signs, it's possibly a multiple system atrophy. If there is significant dysautonomia, it is possibly multiple system atrophy. And again, if the patients have lots of dysarthria, dysphonia, or stridor at night, or even in daytime, then multiple system atrophy is a possibility. And very rarely, if patients have myoclonus or the well-described but less often seen alien limb phenomena, or apraxia, which is difficult to identify often unless one looks carefully for it, it's corticobetal syndrome. Dementia, Alzheimer's disease, a big one that's going to hit us very soon, including cerebrovascular disease, can be from other causes as well. Dementia with Lewy bodies, progressive supranuclear palsy causing a subcortical frontal lobe syndrome, or corticobasal syndrome can also present with dementia. This talk of mine is aimed primarily at the third year MD and first or second year DM neurology students, but it's applicable for all practitioners of internal medicine because these patients come and see us on a daily basis. So I'll be pitching the level of the talk to that level, slightly higher than the Parkinson's talk from the last session. Right, let's start with looking at a few videos. First of all, let's look at some of the patients who look like they have Parkinson's, but eventually turned out to have a different condition.
Stay there.
Resting tremor, asymmetric.
As quick as you can.
Bradykinesia. On the right hand first.
The left hand.
The left hand now. Significantly worse. You saw the tremors worse on the left side as well. Watch the amplitude and the speed of the tremors going down as the patient repeats.
Like you're putting in a light bulb.
Examining the patient. Tremor is actually, you have to hold the patient's hand, but you can see pretty much here some element of cogwheeling that's there. The legs also are stiff.
Okay.
The left side is more affected. So you saw it there. It looks like Parkinson's, but these patients eventually did not turn out to have Parkinson's disease. Just giving you examples of how things might look like Parkinson's, but they are not. Limb akinesia.
In die andere Richtung?
Rapidly touching the fingertips with the thumb tips. See the bradykinesia on the left hand. Now, the characteristic description is that when it's not Parkinson's, there is less response to levodopa. Watch this patient before and after levodopa. Also observe the movements around the mouth. This is multiple system atrophy. Before and after levodopa, there is not much of improvement. Before levodopa and after levodopa, usually there is a much bigger improvement that we can see. We don't see it here. The giveaway is here. the finger nose test. This is MSAC, multiple system atrophy cerebellar type, and you can see the ataxia on approaching the target, the examiner's finger. Asymmetric, but cerebellar sign very early on, MSAC. Patient now asked to tap the feet. So before levodopa and 1 hour after levodopa. Not much of movement. Now here we will see the rocket sign, which again we'll see at the very end, but here you see before levodopa, the patient is being asked to arise from the chair. And after levodopa, see that sudden dropping back, that's a loss of postural reflexes. That's the rocket sign that we see in this particular case. Right, now moving on, the next video, watch the patient's face as you watch the hands being moved around as well. Can you see the surprised look on the face of the patient? That's the Procerus sign of PSP, and the great rigidity on turning the head from side to side, plus the bradykinesia that you see in the finger tip movements. This is going to be progressive supranuclear palsy. Next, watch this particular video. Again, you can see both hands bradykinetic, worse on the left side, but significant neck rigidity and knee and neck flexion and extension rigidity. And anybody could diagnose these patients as having Parkinson's disease. But as I was mentioning to you, the eventual diagnosis and the subtle signs that you see, which will vary depending on the stage of the illness, will make it the other alternatives, which are not uncommon. Parkinson's disease, next comes vascular Parkinsonism, next comes PSP. So very important to diagnose them. Now, talking of vascular Parkinsonism, we all know from third-year days that there is a lower limb predominance and asymmetry.
Finger taps as big and as quick as you can.
Watch this particular patient being asked to move their fingers.
And
there is not much in way of bradykinesia when the patient is moving the fingertips very quickly. So,
like if you're trying to put in a light bulb, I know the light bulb is not like that, but you get the idea. Well done, perfect. With the right foot, do this for me, please. Tap, 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 tap. Loud taps, I want to hear them.
Watch, hear the voice as well.
And with the left. And if you lift your right foot from the, or your right leg from the hip. Okay. More difficult. And with the left? Okay.
So this is vascular Parkinsonism. 2 points to note. Upper limbs were fine. Legs showed the reduced tapping speed, and the voice you could hear in the background shows the typical hyperphonic speech. The other thing I'm going to show you now is this pull test. Keep watching. I'll be showing you a few of varying severity. Very severely affected pull test. Lack of postural reflexes, lack of being able to balance. Unless the examiner catches the patient, he will fall and suffer injuries. That's what happens. Here, the lady pretty much falls down like a tree back onto the examiner. Here, you'll see the pull test. It's not that prominent. Just 2 steps and the patient stops. Watch again. But watch the next one as well. Here it's more subtle. 2 steps, 3 steps. lack of postural reflexes is what I was trying to get here. Right, anyway, so the introduction, few videos I showed you was to emphasize that these patients all look like having Parkinson's disease, but they have a different diagnosis. And we know the diagnosis that we are looking out for. Why do we need to make the difference clinically, through history and through examination, through pattern recognition, and about knowing the features that we're looking for? Purely because Parkinson's disease has got a better prognosis than these. Therapy with levodopa and other sort of pathways make a difference to the patient's quality of life. Levodopa helps. As you saw, the levodopa response was poor here. Surgical interventions, which we will be eventually doing more and more in the coming years and decades, works for Parkinson's, does not work for these conditions. Hence, 3 to 5 year cutoff points are being used so that DBS is being offered, deep brain stimulation is being offered for Parkinson's patients. Patients require wheelchairs very early. Prognosis is poor, and I will discuss that in a minute. And there is greater carer burden, carer support for these conditions. Hence, we need to make the distinction very early on to get the right diagnosis. So this slide lays out for you the essential bullet points of the conditions. Multiple system atrophy, partial response to levodopa is there, not complete response, but very early autonomic function disturbances, falls, early bulbar symptoms, so there's a risk of aspiration and choking, and survival 6 to 9 years. PSP again shows a partial response to levodopa, but severe postural instability, as you saw in the previous videos with falls. They have early bulbar involvement, there is subcortical dementia, very bad prognosis, 5 to 8 years. And rather common actually, PSP after Parkinson's, there is a lot of PSP patients that are diagnosed. Corticobasal degeneration, thankfully, rather rare, again showing a partial response to levodopa, but they have myoclonus, cortical signs, falls and dementia and dystonia. Survival again rather poor. So let's start the detailed discussion on each condition now. Multiple system atrophy terminology has evolved over the years and decades. The striatonigral degeneration, SND, is now called MSAP because it's got multiple system atrophy Parkinsonism variant. Then there is the olivopontocerebellar atrophy, which is now the MSAC, MSS cerebellar. And then the Scheidegger syndrome, which had a predominance of autonomic nervous system manifestations, is the MSA that presents with autonomic nervous system dysfunction. So these are all synucleinopathies. Synuclein is the protein aggregate and synucleinopathies. Now let's look at the multiple system atrophy patient speech.
How can I know with the speech, when I was walking around, it's kind of slow moving, and it'll respond to my arm on the left and on the right leg, on the left leg.
Okay. Now, did you have some stuttering problems when you were younger?
Yes.
But did they go away essentially completely?
Yes.
Okay.
So here you hear the speech of the patient, which has got both Parkinsonian elements as well as a slurred component, a strangled component, which is pyramidal in type. So there is the combination of the two. Now, again, this particular patient, you will see.
What did you have for breakfast? You had oatmeal. Okay. Can you repeat the sentence after me? I only know that John is the one to help today.
I know John is going to help me today.
The cat always hid under the couch when dogs were in the room.
The cat always hid underneath when the dogs are in the room.
Right. So this is a patient of MSA, most likely clinically, because of the lateral oculus that you see out there. And then again, this was actually a video to demonstrate to you the hypophonic speech and the dysarthric speech at the same time. Now, what's the epidemiology of MSA? Now, this is Western literature and Japanese literature I'm pointing out to you. So I don't have access to any Indian epidemiological data, which we must develop in the coming decades through the Movement Disorder Society of India and the IMA. Now, the Parkinsonian variant is much more than the cerebellar type in most countries. And in Japan, the cerebellar subtype is more frequent. So there may be some genetic or epigenetic factors that determine it. We've talked about the median survival. Again, I mentioned 6 to 9 years, 6 to 10 years. Occasional patients survive for longer. Now, for the consensus criteria, the diagnostic points for probable multiple system atrophy is the early appearance of autonomic failure, urinary incontinence, erectile dysfunction, orthostatic hypotension. We talked about partial response or poor response to the Parkinsonian symptoms, and a cerebellar disorder. And you have seen my lecture on ataxia about the cerebellar syndrome. When it's a possible multiple system atrophy, then we get an excess amount of Parkinsonian syndrome, and then a cerebellar syndrome, and at least one of the autonomic features that we have. Now, as I mentioned earlier on, Parkinson's disease, MSAP, and dementia with Lewy bodies are synuclein deposition diseases, whereas the other conditions are tauopathies, which is the basic protein deposition in the brain that causes the disease. It's important that you know about this. Now, additional features of possible multiple system atrophy. Multiple system atrophy, as in there is basically the extrapyramidal system, cerebellar system, pyramidal systems, and we can see out here the autonomic nervous system involvement, the stridor, the cerebellar, the postural instability is there as well. Very early on, Parkinson's patients get postural instability 10, 15 years into their illnesses. There is also dysphagia arising, and hence the risks of the same. There are some imaging modalities that are being picked up, like atrophy on the MRI and FDG PET studies showing hypometabolism. And that's the distinction between MSAP and MSAC distinguishing points. These are basically synucleinopathies that we are identifying out here. It can affect cognition and behavior. There is definitely a executive dysfunction and dementia appearing, and depression, anxiety, and apathy with MSA. So as you can see, it's a multi-system disease, hence multi-system atrophy, affecting the neurological axis, the psychiatric axis. It affects sleep, REM, sleep disturbances, ear, nose, throat disorders, stridor, as we have talked about, aspiration pneumonia, and there's a large amount of autonomic nervous system dysfunction from a dermatological perspective, hypohidrosis, anhidrosis. There is a erectile dysfunction, nocturia, urinary frequency, constipation, and there's also a huge significant impact on cardiological manifestations. So it's a multi-system disease. The natural history, this is roughly from when we start to diagnose the patient either with Parkinsonism or cerebellar features. There may be a bit of stridor at night, but there are quite a lot of symptoms that happen even before these motoric symptoms start to take place. And then as the condition gradually progresses from the 6-year time point, falls, need for catheterization, speech becoming unintelligible, as you saw in the first video, leading to interventions and eventual patient's demise. So the differential, as you can see, when we meet the patient for the first time, can be difficult, but when we are looking actively for the other differentiating points for the other conditions, as we talked about, the Scheidegger, the cerebral ataxias, the DLB, and other atypical Parkinson syndromes, then MSA becomes a possibility. Clinical diagnosis, even among movement disorder specialists, is 88%. There's a 12% misdiagnosis rate. Bring it down to the general neurologists, it dropped to about 64%. We are trying to improve that figure. MRI, brain imaging, and SPECT imaging, and cardiac sympathetic imaging, MIBG scans, and I'll show you some pictures, do help, as do autonomic nervous system, and anal sphincter EMG to look out for degeneration of the honest nucleus. That's quite specific in this condition, but they're not specific or sensitive to 100%. So to give the patient a diagnosis in life better than 88% among the best of people who know and make a living out of multiple system atrophy, we've got to increase the appreciation rate of diagnosis. A few of the imaging that we talk about in exams, the hot cross bun sign that you can see is the hot cross, the pontine fibers crisscrossing the pons like a hot cross bun, or the plus sign. And of course, you can see the cerebellum being quite atrophied out here. There are other hyperintense two-terminal rim on the T2 flare sequences that you can see out here, are more recent MRI. Now, there's a lot of Parkinsonism in multiple system atrophy. There is rigidity, bradykinesia, can be asymmetric, but eventually they rapidly become bilateral. There is tremors, but they have a myoclonic component, and I'll show you that in a minute. There's rest tremors, but not the pill rolling type of tremors. That's a pattern recognition that you will have to develop. And the very early falls and postural instability compared to only 2% in PD, whereas 20% in MSA, and the pull test that you saw. So there's consensus criteria. We have talked about this in the earlier slide, and this is summarized of what we're expecting and probable and possible, because definite is only on autopsy. So the possible MSA criteria, again, the Strider and the Babinski sign with patient with cerebellar and extrapyramidal makes it high likely, whereas the other ones make it lower levels of certainty. There is possible to differentiate MSA-P and MSA-C. Now, what are the features that do not support an MSA diagnosis? Remember, we had some orofacial movements, dyskinetic movements, dystonic movements in the first patient, or a disproportionate anticolis, whereas, or camptocormia. I've shown you pictures in the previous Parkinson slide, the Pisa syndrome, severe lateral flexion, or contractures of the hands. These are all the positive signs of MSA. Whereas if the patient has the classical Parkinsonian tremor, or a neuropathy, or DLB-like features, dementia with Lewy bodies, or a much later presentation, or some genetic varieties of spinocerebellar ataxias, or dementias, or white matter lesions, then it's not going to be multiple system atrophy. We've talked about the multiple system atrophy pathology, where the hallmark is basically the cytoplasmic alpha-synuclein positive glial cytoplasmic inclusions within the oligodendroglial cells. Moving on to the next disease, which is dementia with Lewy bodies, DLB. Now, Lewy body dementia is actually an umbrella term where Parkinson's disease patients, after a longer period of time, develop dementia. And that's the Parkinson's disease dementia subtype, whereas the dementia with Lewy bodies develops dementia as the presenting illness. I'll show you the criteria in a minute. So it's important because after Alzheimer's disease, DLB happens to be the most frequent neurodegenerative dementia. And it represents between 4 to 30% of dementia cases. And there is a lot of underrepresentation, and autopsy again reveals the diagnosis. So in the dementia with Lewy bodies, the Parkinsonism is seen in about 50%, up to 50% at time of diagnosis, and eventually up to 80% will develop the disease as time goes by. It is again a very symmetric disease with axial rigidity and postural instability compared to Parkinson's. And there is a rapid UPDRS, Unified Parkinson's Disease Rating Scale, 10% getting worse every year, not as fast in Parkinson's disease. And again, partial response to levodopa. What happens in Lewy body disease is that Lewy bodies is actually found in normal subjects, including in the peripheral nervous system, but we get early appearance of smell disturbance, constipation, mild cognitive impairment. These are prodromal features. And Heiko Brack staging, that we use for Parkinson's disease and for these conditions show the ascending progression of pathology from the dorsal vagal nucleus to the neocortex. And there is a spread of synuclein that occurs through the neuroanatomical connections. It's a synucleinopathy. So dementia with Lewy body criteria for diagnosis is based upon the central features, should either precede or occur with Parkinson's. There should be dementia affecting attentional systems, executive dysfunction, visuospatial, and later memory impairment. And this is important and as a hallmark for dementia with Lewy bodies because these patients get recurrent visual hallucinations, which are well formed and detailed. They also get REM sleep behavior disorders. And the very characteristic one is this fluctuating cognition with pronounced variation in alertness and attention. So these are the basic points of dementia with Lewy bodies. In addition, they have severe neuroleptic sensitivity. That's often found out through an iatrogenic, symptom elaboration of severe neuroleptic sensitivity. Patients have repeated falls. They have postural instability and autonomic dysfunction. And there are cognitive symptoms, depression, apathy, anxiety. When we do dopamine transport scans in the basal ganglia, there is reduced uptake seen. And from the autonomic nervous dysfunction, we get to see cardiac MIBG abnormalities. And the polysomnography, PSG, shows REM sleep without atonia. There are a few important biomarkers on FDG PET, like the cingulate island sign that we see, and on SPECT perfusion. But again, these are supportive, but not specific. So that led to the revised criteria for DLB. And you can see why it's important because Alzheimer's disease, dementia with Lewy bodies, Parkinson's disease, dementia are all sort of in a spectrum, and patients need to know because of the varying prognosis of these various conditions. And we need to rule out the cerebrovascular disease on brain imaging and Parkinsonism being the only core feature for DLB diagnosis. So this particular McKeith classification from 2017 raises the revised criteria for the dementia with Lewy bodies. I will refer you to the original paper, but essentially you need dementia and which domains we can see out here. And then we need to have a fluctuating cognition with variations in attention and alertness. There needs to be recurrent visual hallucinations, typically well-formed and detailed. There is also REM sleep behavior disorder, which may precede cognitive decline. And then we have the Parkinsonian features like bradykinesia, rest tremor, and rigidity. This is what you know of. Plus, there are supportive features of antipsychotic sensitivity and the autonomic nervous system dysfunctions that are enumerated here. So the indicative biomarkers we talked about are the SPECT scan, the MIBG, the polysomnography, and the various different cingulate island signs, and you can read the rest. So in the dementia with Lewy bodies, there are multiple domains of dysfunction that present to you, which makes diagnosis easier. And here are some MRI and PET scans, SPECT scans out here, which show Alzheimer's disease where it is normal, but the MRI shows significant medial temporal lobe atrophy, parietal atrophy. This is basically the dementia with Lewy bodies where there's a significant abnormality in the dopamine uptake scans out here, but the MRI remains normal. And this is the normal control where the MRI is normal and the normal SPECT scan. Here we get the MIBG scan of cardiac autonomic denervation. And you can see how in Alzheimer's and in normal subjects, it's normal, whereas there is a significant denervation in the DLB patients. And that's again reflected out here. The DLB pathology is often sort of synucleinopathy, as we talked about, synuclein, alpha-synuclein. And this is the Alzheimer's type pathology. And there's an amount of overlap. And this particular paper and the diagram will tell you more about the Braak's classification and staging in relation to the Alzheimer's, DLB, PDD, Parkinson's disease dementia, and the dementia with Lewy bodies. differentiation. Let's move on now to the next disorder, which is progressive supranuclear palsy, PSP. Now, PSP, we have all been looking at with the eye signs from our third-year days. It's about 5% of Parkinsonian patients in a movement disorder clinic. So it's there. It's just that we often confuse it with Parkinson's disease. And because of methodological issues, PSP has been underdiagnosed, but things are changing. Let's look at some patient videos to remind you.
Meinen Finger oben und dem Finger unten hin und her zu schauen. Und wieder nach oben und nach unten und nach oben und nach unten. Jetzt mal an die Decke schauen und nach unten schauen und an die Decke schauen und nach unten schauen und mal nach rechts. Sie schauen immer auf meine Nase. Super. Sieht man das auf dem Video?
Ja,
super.
Das sieht man.
Right. So what you saw, there is possibly a revision for all of you where the patient is unable to generate vertical sort of saccades, but there is presence of oculocephalic reflex, which proves that the patient is able to move the eyes upwards, but cannot do it on volition. And the patient generates head thrusts to initiate those movements. You can see that. I'll be showing you a few more of that here. See, horizontally, the patient is able to generate them, but on vertically, she is not able to do that. And the examiner quickly shows you the oculocephalic maneuver to show that the vertical movements are preserved when there is the oculocephalic reflex presence is shown. The next hallmark of PSP is this eyelid opening apraxia. Watch the eyelid opening apraxia.
Nakliste tamatie swichta. Swichta. Ωραία. Και τώρα ανοίξτε.
The great difficulty of patient.
Μπράβο.
So the patient closes the eye and then is unable to open it, apraxia. Again, another patient showing the same phenomena. Closing the eye, asked to open the eyes. Not as bad as the previous one, but it's still there. We have looked at a few falls. These are all the PSP phenotypes. See, lack of postural reflexes, keeps going back, and eventually will fall unless somebody catches the patient. The applause sign is again a very characteristic.
Darf ich Sie mir mal bitten, das genau so nachzumachen, wie ich es mache? Ja, machen Sie es nochmal genau, Entschuldigung, nochmal genauso wie ich, nur 3-mal.
So the patient carries on applauding and is unable to stop. Again, another one.
Genau die Anzahl von Klatschern nachmachen, wie ich sie mache.
3 times.
Okay.
Carries on. So the next sign I'm going to show you before those classic vertical eye movement abnormalities is this macro square wave jerks. Watch. The patient is being asked to focus on something the examiner is holding. And can you see the very subtle square wave jerks that you can see out here? And this is the earliest sign of the eye movement disorders that you see in PSP. They can be, I've got a few out here to show you, very subtle. Another one. So that's a square wave jerks. These happen long before the patient develops the eye movement abnormalities. This is a classic abnormality of eye movements in progressive supranuclear palsy. Horizontal movements, slow saccades, slow pursuits, you can see. but no vertical.
Up. Look up. Look up. Okay, look down. Look down. Look down.
Cannot look down. Cannot look down. And you can see the eyelids not opening very well. So some amount of apraxia developing when the patient looks down. PSP in early stage can cause dysphagia. Watch.
Okay.
Very early dysphagia developing in PSP.
Okay.
Life-threatening because of aspiration pneumonia risks. Listen to this commentary.
This 68-year-old woman has a 10-year history of progressive gait and balance difficulties, bradykinesia, dysarthria, and dysphagia, unresponsive to levodopa therapy. The complete ophthalmoplegia, retrocollis, and striatal hand deformities are typical features of progressive supranuclear palsy.
I wanted to show you, as I was moving the arrows around, was this striatal hand. Striatal hand. It can be confused with rheumatoid arthritis. They may well have rheumatoid arthritis because of the same age that it develops in, but it's this very striatal hand that sort of tells you it's a PSP. So after having showed you some of the features on video, which is movement disorder is basically a video sort of specialty, it's a progressive disorder with Parkinsonism, symmetric at onset, early falls, vertical supranuclear palsy, dysarthria, axial rigidity. You have seen the blepharospasm and the apraxia by opening with frontal lobe dysfunction. So that's the features that makes it PSP, progressive supranuclear palsy. And basically exclusion criteria is there, hypokinetic, spastic dysarthria. We've seen all that. And there are some imaging markers of PSP, which I will show you now here. This is the classic sort of MRI, the hummingbird sign or the penguin sign. The midbrain suffers extreme amount of atrophy, so it's very small out here. Whereas you can see the different types of MSAP that you can see out here. Now here we have the advanced PSP and the mild PSP differentiation as well on video line and markings as well. So this is Parkinson's disease is normal, whereas the patient with PSP, apologies for the previous demonstration, this shows the marked atrophy of the hummingbird beak and all, and this is the MSAP, which also shows, but not to such a big extent. So the PSP syndromes have been now reclassified. Again, it's getting more and more complex. It was very easy about 25 years ago when I first started doing neurology training, 1995. But since then, it was quite cast down. DLB, PSP, MSA, Parkinson's, and there were a few behavioral variants of FTDs being developed then. But now, everything is getting blurred, not least because the synucleinopathies and the tauopathies seem to be merging, and there seems to be a relative abundance or spectrum of distribution. The neurofibrillary tangles and plaques and Alzheimer's discussion has also been progressing. MND has been coming in. Genes have been coming into the discussion. So the genotype, phenotype, pathology types, and autopsy and clinical correlations, imaging correlation has made the subject and the field more and more complex. Well, here is actually a classic example of how the PSP syndrome has evolved from the time I studied it, when it was only these that we had, and we didn't have all the regional pathology in the various brain structures, but we have now teased out PSP to be PSP Parkinsonism, PSP with PO akinesia with gait freezing, PSP with the corticobasal syndrome phenotype, PSP with the behavioral variant of frontotemporal dementia, PSP MND variant, primary lateral sclerosis variant, and PSP cerebellar. So all this happened in the last 25 years during my time in neurology. So we are trying to just stick to the basic identification of PSP being the frontalis overactivity which I've shown you, the reduced blink rate, the Procerus sign you saw, the retrocollis, the commentary in the patient, falling backwards. We have seen one rocket sign before, the messy tie sign, where the food spills because of dysphagia and the axial tone, and they can't see into their plate. We have seen the applause sign. And of course, there is a lot of reduced reaction time, bradyphania, that we see here as well. So the Parkinsonism in PSP, because we are trying to distinguish what looks like Parkinson's disease, is not Parkinson's, but there are hints of Parkinsonism in PSP. So there is some bradykinesia. At diagnosis during the illness, there is axial rigidity and nuchal rigidity. There are tremors, but there are distinguishing points, and I've mentioned them there. Now, Professor Hoglinger has been trying to make the diagnosis of PSP more secure. And you can see we're moving up from a level 3, which is the least specific, to more specific, which is level 1, on all the 4 domains of eye movement abnormalities, and you've seen all this in the videos, the postural instabilities, and I've shown you the various degrees of postural instability, the akinesia that we have seen. We've seen the phasing of gait in the previous Parkinson's talk, and we have seen the cognitive dysfunction of the corticobasal syndrome. I'll show you more of the frontal behavioral presentation and the cognitive dysfunction. I haven't shown you so much of that. And the clinical clues are along these lines as well. There are levodopa resistance, hypokinetic, spastic dysarthria. You have heard the voice. And there is dysphagia. You've seen the Persian cough and splutter, and there is photophobia as well. And there are imaging correlates as well, including on radioligand scanning that we have seen. Now, so basically the reference is here. You can look at it about the mandatory inclusion criteria for PSP and the mandatory exclusion criteria. And I will be discussing these in the second part another day of the atypical Parkinsonian syndromes of other conditions that can cause a Parkinsonian phenotype. But have a read of this. And we have mandatory exclusion criteria on imaging and normal pressure hydrocephalus. That's next session. And there are CADASIL and DWI features. Not forgetting the other conditions like Wilson's, Niemann-Pick. This is the alternative Parkinson's disease, secondary Parkinson's disease, and prion disease, and paraneoplastic and autoimmune encephalopathies that we also have to consider. So there are other exclusion criteria. We will not be going into the genetic Parkinson's disease at this level, but perhaps for neurologists, I'll be giving a separate talk on Parkinsonian genetics. So that's for another day. Moving on to the last talk for today, I'm mindful of the time, corticobasal ganglion degeneration, CBD. Let's look at some videos again. So, Lima.
¿Cómo dirías adiós? ¿Y con la otra mano? Di adiós.
No.
You saw how difficult it was to wave the hand with the right hand for this particular patient. Here you will see 3 things the patients are being asked to do.
I want you to close your eyes. Now open them. Okay. Are you trying to open them?
Yes.
Keep trying. So the patient had difficulty opening the eyes. So not only in PSP, also in CBD, we get the same problem. The next video.
Peace sign?
Peace sign.
No, peace sign. Get the peace sign.
I can't get the peace sign.
Give it a shot.
Was asked to make the V sign or the victory sign like that. Can't make it.
Can you try to do this? A thumbs up sign? Thumbs up. Try it.
Thumbs up sign, cannot do it. So apraxia. They also have dystonia.
Ahora, levanta tus brazos.
Watch these.
Hacia arriba.
Dystonic posturing that you see in that particular hand. The next thing, myoclonus. Stimulus-sensitive, a tap reveals more myoclonic movements. It's not tremor. It's not tremor. Shock-like myoclonic movements. Alien limb phenomena, we all talk about
Can you
it.
explain me a little bit what happened with your arm and your leg?
Well,
Listen.
I have weakness in this arm and this leg. And I have...
Tell me about the involuntary movements you were describing before.
Involuntary movement of this arm.
Are they like this, like you are doing now?
Yeah.
Okay. And what about the legs?
And the legs, I have this movement.
Okay.
The only way I can stop it is if I stand with my legs wide apart. And the only way I can stop this hand movement is if I put my hand in a fist and I hold my arm straight and strong.
First with the right side to start with. Can you stop doing the movements with your left side or not? It's involuntary, the open and close? Your left side? Okay, now.
Right. So you saw out here what was the alien limb phenomenon affecting both the upper and the lower limbs. And she described to you, patients are our best teachers, of what actually happens. If you can catch an alien limb phenomena, you will see how the patient has got very poor control of the affected limb. It's to do with the sensory deficits and the gating mechanisms, which do not control the motor behavior. So there is a sensory and the motor loop problem in the parietal cortex that gives rise to this. Now, watch this one, cortical sensory deficits.
Putting something in your hand, tell me what it is.
I don't know. No clue.
Okay, what is it there?
See.
Okay, what is this? Just feel it with your fingers.
I don't know. Paper clips. No idea. Coin.
Right. So there you saw Tony Lang, Professor Lang, showing us the AST diagnosis on the right hand. Now, again, you see another feature of apraxia. Left hand is struggling to make the OK sign, where he's asked to make opposition movements of the two. He's asked to do that sort of movement, but he can't. Right, moving on. The pseudobulbar affect that you see.
What you think is wrong?
What do you think is wrong? What do you think is wrong?
Tell me what day it is today.
Yes, what day is it today? Yes.
Do you know what day is today?
What?
It's okay.
Because I know they asked you before, but they want to know again.
Is this laughing bothersome to you?
Bothersome.
Does it upset you? Okay. Is this worse than usual?
Yeah, much worse than usual.
Okay, so it's probably the stress of... Do what I do when I'm finished. Okay?
This is very
Watch this. Okay? Now what I want you to do is clap 3 times. Clap 3 times.
3 times.
Right. So what you saw Professor Lang showing out here was the pseudobulbar effect, where the patient went on to have pathological sort of laughter, which he could not control. You saw that twice, but in addition, you see the applause sign, which I've shown you before, and there is also some amount of echolalia that he does. He repeats the instructions for himself. So that's an interesting thing. Now you see the Luria motor sequence.
Repeat what I'm doing, okay? Okay, let me do it again. Okay.
Right. So again, you see the Luria motor sequence you will learn in neuropsychology is again a manifestation of cortical pathology. Now again, we come on to the echolalia and pallida.
You know the complete day today?
Complete day today.
I don't think we know that. No one
It's okay. All right. Now, who is with you right now? Here.
Yeah. Who is with you right now? Here. Yeah.
So.
Okay. Now, can you show me how you comb your hair?
Comb your hair.
Echolalia.
Okay. How do you brush your teeth?
Pallilalia. It's being asked for apraxia. Can't show it.
What did you have for lunch?
What did you have for lunch?
Right. So in corticobasal disease, corticobasal syndrome, it was first described with that particular nomenclature when they had asymmetric skinetic-rigid syndrome, and there was 4 R-tau in the neurons and glia, and so that's the paper I'll ask you to have a read at. The corticobasal degeneration, you've seen a lot of the features here. There's a markedly asymmetric, and it's quite rare. They do have a lot of apraxia, alien limb that you saw, and cortical sensory loss. There is dystonia, which can exist in other conditions. There is myoclonus. I've shown you myoclonus, and there is a dementing disorder, and there can be aphasia as well. Now, here we get to see the imaging of the corticobasal ganglionic degeneration, which is a tauopathy here with astrocytic plaques and ballooned achromatic neurons with a frontoparietal asymmetric atrophy that's been seen out here. You can see the asymmetry, frontoparietal atrophy that we see out here. Now, what are the Parkinsonian presentations of CBS? Again, we get asymmetric, slowly progressive, single limb getting involved, mainly the upper limbs. There can be a good response to levodopa initially or partially, and there is a myoclonic component to the tremor. There is also a postural instability that we can have. And this particular sort of table shows you the probable corticobasal syndrome, the possible corticobasal, and there are other types of frontal behavioral spatial syndrome, non-fluent or agrammatic variant of primary progressive aphasia, and the progressive supranuclear palsy syndrome. So these can be all the thing. Again, 25 years ago, it was only up to here that we had probable corticobasal and possible corticobasal with the things that you've seen already, the limb rigidity akinesia, the dystonia, the limb myoclonus, and the orobuccal limb apraxia. But the other, the language disorders that we also see, impaired grammar, sentence comprehension, single word comprehension, these are more recent definition terms that we are getting out here. And there are research criteria for corticobasal ganglionic degeneration. I'll refer you to the Armstrong paper from 2013 and more recent ones. Well, that was the part 1 of the atypical Parkinsonian syndromes that I talked to you about. I've dealt with the 4 main neurodegenerative disorders. Next time, I'll be talking about the vascular, the toxic, and the other sort of, more easy to deal with Parkinsonian syndromes. The videos, I'm very grateful to MedLink Neurology for Professor Joseph Jankovic's videos. I would ask you all to look at the video tutorial for movement disorders on the PSP, where there are a large number of other videos. The recent edition of Bradley's Neurology in Clinical Practice is out. That's in electronic format. You'll get lots of videos to look at there. And International Movement Disorder Society is free for Asia, Oceania. So I would invite all MD students to become members for no cost to the International Movement Disorder Society. And a lot of the slides I have taken from the Dr. Jennifer Goldman's Aspen Movement Disorder course from this particular year. Thank you for listening, and I wish you all the very best till next time. Stay safe, stay well, and observe social distancing, get vaccinated, and advise your friends and neighbors to do the same, and follow the administration guidelines. Long live IMA. And if you have any questions, you can post them to me on my email address, or use my email rather than using public forums for communication on medical matters. And thank you very much. Thank you. Bye-bye.